We had sinus. What else? This should be kind of top of mind.
You can have AV block.
Heart block. Good. What levels of heart block exist that would be pertinent to pacemaker implanting? Yeah, we get second. Third. And what else? It could be first, but you need to be symptomatic, right? The general rule of thumb now, particularly with the new ICD 10 indications for implant, is that the patient has to be symptomatic.
That's for insurance purposes, right?
It's for Medicare purposes and insurance. Yeah, private and public insurance. So this is good. We're almost there. What are the potential, or what are the different types of pacemakers that we might implant for bradycardia?
Dual chamber.
Yep. What else?
Single chamber.
Yep. What else? What's the single? And what's the dual? What are the chambers we're talking about?
Right atrium.
Yep.
Versus right atrium, right ventricle.
Okay, so you're saying right atrium versus, you're saying there's an option where we would put in a lead in just the right atrium?
Isn't that a single chamber?
It's possible, but it's very uncommon here.
SA node dysfunction.
That is where it's needed, but in the United States, if you have SA node dysfunction, the vast majority of physicians are going to like to put in what? We did talk about this one.
If you have SA node dysfunction, they will elect to put in
Single, dual, or bi-V? What was it?
5E, right?
I gave that option, but let's go single or dual?
dual.
Dual. They're going to put in a dual if you need atrial pacing. And the reason is that the patient goes home and develops heart block, that they are protected. Right?
Okay.
Where would you put in a honest-to-goodness single chamber? Yeah.
What's the difference between 5E and dual again? I thought dual was 5E. I'm confused.
So technically 2 Vs is 2, right? But in EP or in implanting cardiology, they're going to refer to a dual chamber pacemaker as A and V. Specifically RA, RV.
Okay.
And it's to resynchronize the A and the V in situations where you have heart block, either first, second, or third degree. Right? If the patient has low ejection fraction, wide QRS, electrical dysynchrony producing heart failure, then bi-V, which could be either 2 leads or 3 leads. Why would a bi-V only be 2 leads? Just like why would we only put in a ventricular lead and not in the A? When do we ignore the A?
When the rhythm is only coming from the ventricles, you don't need the.
So, not really. So,
Complete heart block?
complete heart block, we're going to put in what?
Dual.
Dual. Yep, we want to listen to the A, we want to pace the V. Right? We want to reconnect what the AV node is not doing. The bi-V can do that, right, if we need to pace both ventricles simultaneously or with some sort of pre-prescribed delay. We have a presentation. We'll get to this in a minute. We're going to talk about CRT in a minute. So, single chamber only in the V is for patients with AFib. Why do we not put an atrial lead in the A when they're in AFib?
Because there's too many foci firing.
What's the point?
Yeah.
If you can't pace it, we're not going to put a lead there. This is for chronic fibbers. If they're just paroxysmal, you can put a lead in the A and it becomes very useful. Put a lead in the A when they're in paroxysmal fib, and you can know, like, is the medication working that I'm trying to reduce their AFib burden? If they got an ablation later, did it work? What's their percentage? Are symptoms that they report back to clinic correspondent with episodes I see on the recording? Atrial leads are also really good at diagnosing VT versus SVT, right? So let's go to, is that reasonably comprehensive for types of pacemakers and reasons you would put them in? Second degree block, what kind of pacemaker?
Dual.
Dual, yep. Heart failure, what kind of pacemaker?
Five.
IV. Yep. AFib with heart failure, what kind of pacemaker?
Five.
With no A lead. 2 leads only. RV, LV. In fact, we don't put it directly in the LV. Where do we put it? And this is going to get into what we talk about today.
Is that
Where does it go?
like one of the vessels?
It is one of the vessels. What's the big return vessel? The gutter of the heart. Coronary sinus, right? So we're going to get to that in a minute. Quick review of the ICD stuff. So we said atrial lead is helpful in distinguishing between VT and SVTs. SVTs are a big group. What falls into that group? Could have sinus tach. What else is an SVT? Anything above the ventricles?
AFib.
AFib is an SVT, absolutely. What else?
WW.
A flutter is an SVT. What did you say?
The reentrance.
Reentrant tachycardias that include the A, right? So AVNRT, AVRT. What's the difference between AVNRT and AVRT?
AVRT is the AV node and the bundle of Kent stuff.
The Kent bundle is the old term for it. We just call it an accessory pathway now. But you were absolutely right. Yeah. Right? If you have an accessory pathway that is producing a wide or pre-excited QRS in sinus, that is referred to as what? That's the old school term. WPW. Yep. WPW basically describes the presence of a bypass tract and usually pre-excitation in sinus. You can then have tachycardias that are dependent on that. They don't call the tachycardia WPW. You don't come into the ER and go, they're in WPW. No. Right? Say they're in SVT, right? And so how would it distinguish itself from VT, from a surface lead perspective? Also from like, just clinically. What's SVT and, how are SVT and VT going to look different?
Will SVT still have P waves and then VTAC? You can't really make out a P wave. This is a wide.
So, good insight, but VT can produce, the A is being activated sometimes via retrograde, but because VT is wide, you'll cover them up more often than with a narrow complex SVT. It's good.
You can get like the captured beats, right? With VT.
Captured beats, what do you mean?
Fusion beats. Captured beats, like every once in a while a P wave will come through. Or no, it's
If you have dissociation so if you have no retrograde conduction, right, it's not going up the node, and you're in VT, regular or otherwise, you would have VA dissociation. You could have P waves occasionally in there. Most of the time, if you're fast enough, you don't see it, right, because the V's are just so wide. So what else can it produce wide complex tachycardia that is technically not VT? No, that is technically an SVT. That's technically VT. What's regular and wide complex, but it's an SVT? It's a type of AVRT.
It's the orthodromic.
It's the backwards one.
Other way.
Antidromic.
Antidromic AVNRT, or excuse me, AVRT. Antidromic AVRT will produce wide complex tachycardia. But typically, they are more stable than in VT. That's the other distinguishing part. They come in an SVT, they're usually going to be stable. Little old ladies, maybe not, but they can convert to VT. That is certainly something that can happen if you're going fast enough and you have an irritable ventricle. So, ICDs are often best served by having that atrial lead there because it allows us information about both chambers. We can see things like, is there an A for every V? If there's more V's than A's, what is it? Almost always. VT, yep, and you're going to need to see an intracardiac recording. But even if you're an ER physician or a GP and somebody brings you a printout, right, or you get an interrogation in the ER where you wouldn't necessarily see device printouts like an EP gets every day, you can see, hey, more V's than A's is probably VT. There are very few exceptions to that rule. So we talked about a couple ways to ablate. We do ablations for SVTs. We do ablations for VTs. Two basic types of tachycardias are reentrant and focal. So reentrant means something's always happening, right? It's always going around the loop, whether it's atrial flutter or you can have left-sided flutter as well. There are some VTACs that are actually considered to be V flutters, but we won't get into that. Basically, it's ringing around the ventricle. Most VTs are going to be focal, so one place is firing. over and over again. There's a quiescent period, right? There's a period where nothing's happening in the chamber, and then the next beat fires up again. So, let's talk about CRT. Okay, so of all patients that get ICDs, this is the breakdown for those that have congestive heart failure and those that do not. So what does CHF mean? From a patient's perspective, what is it producing?
Fluid in the lungs.
That's the congestion part. And why is there fluid in the lungs?
The backups, it's not, basically the heart's not pumping well. And so it's basically backing up the system, kind of like plumbing. And then the fluid, the blood is backing up into the lungs.
You got it. So output is reduced from the left side of the heart that goes to the body and the brain. And so you get backup. The risk for sudden cardiac arrest is dramatically increased, you can see. And this is kind of the breakdown for folks that have it in different heart failure classes. So obviously class 4 has the most. Vast majority of patients that are going to get resynchronization therapy typically have ICDs, and we saw that percentage earlier. But there is an increasing use of CRT therapy or cardiac resynchronization therapy to address heart failure in pacemaker patients as well. If they're not necessarily at risk for sudden cardiac arrest, or haven't had a prior arrest, or have not had an MI that would produce this, but they have heart failure that is wide QRS, low ejection fraction, we think we can solve that congestion with better electrical coordination of their left and right ventricles. That's what we're going to do. We're going to just put in what's called a CRT-P, right? CRT pace versus CRT-D for defibrillate. So you can see these are kind of the basic indications. It's indication for class 1 patients with less than a 35% ejection fraction. That's the magic number. And they're going to be very carefully scrutinized. Physicians in the past that have fudged these numbers go to doctor jail. They do not like that. You can lose your funding, you can lose your research, you can even go to actual jail. So you got to be very fastidious about making sure that you do not, that you are accurate with these numbers and honest about indications. So we also have a QRS width of over 150. In 2008, it was 120. Basically a wide QRS. What's a normal QRS? Yeah, it's less than 120. Most people are in like the 90s. Healthy hearts. And so what's that mean? Why is a QRS wide?
It's not.
It is. And the contraction is a symptom of what function? What's happening to produce the contraction?
The electrical impulse isn't very quickly moving through the tissue fast enough to coordinate.
Right. The overall depolarization of the heart is not simultaneous as it should be. And so the QRS widens and the corresponding mechanical beat widens. And what we can think about this happening, internally in terms of pump function, the left and the right sides are not well coordinated. So you pump the right, typically, and then you pump the left later, you can get a variety of things. One, septal dysplasia. So in the middle of those two pumping chambers, you have something that now has differential pressure on either side. And so what happens if there's higher pressure on the right than on the left when you beat the right?
Right to left.
Right, it goes like, ooh, like that, right? Well, moving walls are not good, right? This wall in particular is supposed to stay very steady, and the outside walls squeeze in. If it moves to allow the blood a little room, where's it not going? Out the valve, right? It's not going to the lungs. And then on the other side, because the left is beating late, that septum goes the other way, and you get less effective pump on that side, right? Which is the really bad part. So you can see there's a lot of detail on here about kind of, breaking down the different class groups for heart failure. But suffice it to say, 35% is usually our cutoff. What is LVEF, by the way? Left ventricular ejection fraction, good. And that's going to be performed using echo, looking at they're going to perform an aortic VTI and also look at the volume, or rather the cross section of the left ventricle compared to at the beginning and the end of the of systole. Okay. Not recommended for class 3 patients. Why is that? Because they are typically have other comorbidities. They're already kind of too far gone to have it. All right. So there is another reason to put in one of these, other than a patient presenting with heart failure already, and that is patients where we know they are going to require a high percentage of pacing with a new pacemaker. So within an AV node ablation, why do we do AV node ablations? Have we talked about this? Mm-hmm. Yeah. What's the number one reason for an AV node ablation? Or basically the reason? Yeah, uncontrolled AFib with we call RVR, rapid ventricular response. And so if you can't get them down on beta blockers, if you cannot prevent the AV node from conducting those impulses through at a symptomatic level, and they have palpitations, and they have fast heart rates, and they can't sleep, and they can't exercise and do their normal things, then it's time to take control. So you knock out the node, usually not in this order, and then you put in a pacemaker. Although some will do that, it just depends, right? So they'll actually burn the node, they'll let the patient go into complete heart block and drop the catheter down into the V and pace, right? And they'll keep that ablation catheter there, pacing, while they then put in a pacemaker. I'm a cautious guy. I like to put in the pacemaker first, but that's just me. And there are lots of studies to support it. Many people have conducted studies, us in the competition, over a period of about 15 to 20 years. This is the most recent type of EP device therapy that's been going in. Skipping ahead. All right, so next, how do we do it? The immune system actually, these are coated with, one, they're inert materials. Scarring does happen, and some people really scar up. They get like really fibrotic, calcified, intense scarring. Other people, not so much. So this is actually a really nice classic system you can see on the right. This happens more often than the one we showed before. So where is the defib lead in this case? First of all, which one is the defib lead? Defib leads, you can always pick out an x-ray because they have to have a coil. And it's a little subtle here, but where's the coil? Nope.
The bottom one.
The bottom one. Wait, because where are you going to put the coil?
Septum. The bottom.
It was in the septum, the other one. In this case, it's where? Yes. And apex, right? End of the line. Right? Here's my mouse. Here is the apex, right there. All right, that's the screw, that's the end of the line. This lighter color here is the coil. Did we focus this time? Can we be more focused? I guess we're just running out of pixels. Okay. So in this case, this device, I believe this is showing a dual coil. It looks like a little lighter color up here. Dual coil leads provide a little faster delivery of energy because their surface area is larger. So they're able to force more current through a larger surface area in less time. We found with patients with high risk for defibrillation, thresholds, we go with these. Put in one of these today in a guy who was 420 pounds. So, good bet.
420 pounds.
420, yeah. Yep. That's definitely a high defibrillation, threshold risk, right? Because it's got a big heart. Yeah, exactly. External defibrillation is even more problematic with people of really large body habitus. Internally, you're really just looking at kind of like, by proxy, then they often have really like dilated hearts. He had a really big heart. It's like a, I don't know about a basketball, but like a volleyball. It was large. We'll call it a softball. What's the big one?
Well, you've gone through all the sizes.
Yeah. Softball's awfully small.
What's the big softball?
Volleyball.
It's like 8 inch.
Oh, softball?
Yeah, there's like a big softball and a little softball. No, big softball. It's like that.
Like a wiffle ball?
Yeah, I was gonna say a wiffle ball.
All right. Well, yeah.
You get the gist.
You get the idea. So, and they actually show a little bit of the venous anatomy here. So where's the valve? Probably. Where's the, and I'm talking about the tricuspid valve. You can go show it on the screen if you want to like go point.
I'm sure you're walking in.
Yeah.
She's telling them she can actually fit.
Yeah, perfect. And it's going to be in, it's going to be in a line like, kind of like that in this view. This is like AP verging on REO. This is more REO. What's that? What's the lead I'm pointing at? This guy right here. I don't have a laser pointer, sorry. I don't know if anybody does, but.
Yeah, no.
Oh, let's go back. Come on now. Mouse. There we go. What is this? This is a BIV ICD. What are we often going to have?
Oh, great.
This is an atrial lead, right? This atrial lead is sitting in the right atrial appendage. It takes the shape of a J. They often do because that's what they look like when we put them in. Some people suck up the slack and then it looks like a hockey stick pointing up that way, but it's supposed to look like this, or maybe even with some more slack going down like this. So this is the right atrium right here. Valve, tricuspid valve. Actually, it's kind of like here because the CS os should be there. And then the CS lead is going around the back and it's going into a lateral vein and stimulating the left ventricle. All right, so it's talking more about our products. There's lots of different things that make them awesome. This is a BIV pacemaker. This is actually our last one. Because this presentation is from 2012. But notice how many leads?
3.
Yeah, good. So this part of the device, I'm not sure if we talked quite about the hardware as much. This part is called the CAN, right? Or the pulse generator. In the pulse generator, you have a titanium housing, which includes all of the sealed hardware. It's got circuit board, it's got a battery, it's got a capacitor, right? Capacitor is really important in what type of device? I mean, it's important for both, but the defib uses that capacitor to deliver all the energy, right? So when you deliver a shock, that battery only produces like 3 volts. That is not going to be enough. You need to get to 800 volts, right? So it's using the capacitor to bank electrical charge, right? It's using the battery over and over and circuit switching, basically, and it charges up to a point where it has enough electrons on each side of the plates, and then it goes, okay, we're ready to shock. Those charge times get longer as the device gets older. And it's one of the limiting factors on the life of the device. Because initially they start at like 7 seconds. And that's great, right? You might not even feel that you're in tachycardia by that point. But at the end, they get to be like 16, 20, they're long. So, and in older devices, they were long. So that's a limiting factor in terms of like how long we can get out of that battery. Up at the top of the CAN, or the pulse generator, is called the header. This is made of a clear, it's like a polyacrylic. I'm not exactly sure what the exact formulation of this is, but you know, it's plastic. And then there's circuitry going through it and lodged in it and you know, all molded in there. And you have pin connectors that go at the end here. You have set screws, which is how we attach the leads in with little hex screws, and we have a wrench that the physician uses. And there's sealing rings on top of those so nothing gets in, ideally. And then you have the next connector here, which goes to the ring. And out here there's more sealing to keep water and blood and badness out. Right? So, yeah.
Do we ever have issues with patients, their immune system rejecting it, the pacemaker?
Very rarely. I honestly, I've heard of one guy where we had to order a gold pacemaker. No kidding. Gold leads, gold pacemaker, because he rejected it. But it's very unlike, because they're inert materials. They're not things that people are commonly, you don't have a lot of titanium allergies out there. Right?
Okay.
Or necessarily like, our leads are made out of, old school leads are made out of either poly or silicone, and newer leads are made out of basically a hybrid of poly and silicone. So silicone is soft, poly is rigid, You mix them together, you get something in between. Oh, and I forgot, I'll bring in the bag. We'll pause the camera and I'll bring in some demos here in a minute. So devices have lots of sophisticated algorithms to help improve things like battery life. They can optimize their outputs so that they only have to use a little bit above what's required because they can test what's required. They can take their own thresholds. And if you can take your own threshold every beat, you don't have to run like 3-4 times what I measure in clinic. You can run like 0.1 margins, and that allows much longer battery life. All right. We also have the ability to monitor patients remotely, which is very exciting. It also makes it so you don't have to put a wand on the patient when they're in the room. You can use a wireless antenna. They use transmission spectrum that's kind of like Wi-Fi, basically. All right, and that is almost it. So this is kind of what the leads look like. This is an older, less sophisticated lead. So this only has 2 electrodes. You can see, kind of the spacing and the shape. And that shape, different brands have different shapes. So you can have S's, there are hockey sticks, there are double bends, there's some that are just straight, there's some that are really tiny for small veins, things like that. One thing that you might see from a clinician perspective, and we'll go back to that earlier slide where I showed them implanted, here we go, is diaphragmatic stim. So you see that in clinic and you also see that in ER. It's a reason a patient might come in. It is not, it is not dangerous, but it is really annoying. So what runs right along the edges of the heart that could cause diaphragmatic stim? Yeah, it's the phrenic nerve. So the phrenic nerve runs right about here, like there. And because this lead is epicardial, it's in a vein, rather than endocardial, way on the other side of the muscle, it can stimulate things that are adjacent to it, like veins, right? And then you get hiccups on one side, right? And the patient's like, what the heck's happening? I feel this, right? So we have ways around that. So one of the reasons that leads have gotten more sophisticated over the years is if you've got 10 different options, you just pick the one that isn't next to the vein. Before, you used to have to, and you still kind of do, you test in implant to make sure that you're not getting diaphragmatic capture. So we'll get a good spot, we'll get the lead out there, and he'll go, okay, max output. So we go all the way to 10 volts, usually you stim at like 2 to 3. Right, but you go all the way to 10, the most the device could possibly put out is 7.5. So we can put even more through the computer. And if they don't do it there, they're probably not going to do it. We test a couple different options, right? We're good. It is still possible. Patients move around. They go home, maybe the lead moves a little bit because they stretched on it, and it moves to a spot where it now captures. Not an emergency, bring them into clinic, we can reprogram it and get around it, which is nice. Okay, so what else? How do we put them in? We use delivery catheters. So this is a couple different types of delivery catheters. You've got a straight one, you've got an angle one. Like I said, they come in lots of different shapes. I carry this giant golf bag with me when we do a BiV. It's not really a golf bag, but and it's got shapes for every different little, anatomical variation. All right, and this is our fancy pants new lead, which we've had for a few years now. The new addition, the product that was actually just advanced, allows us to not only pace from multiple sites, but we can either do 1, 2, 3, or 4. But now you can actually do 1 and 4, or 2 and 3. So you get, instead of just a single site of activation, you get a wide site of activation. You get a wall. And the whole idea here is we want to get all of the muscle as much as we can all at once. All right. Other challenges. Let's see. So unpredictable patient anatomy and pacing performance may lead to implant inefficiency. Some patients, when they have long-standing CHF, their return flow, these vessels, so this is a suitable vessel right here. You could put a lead in that. But in the middle, there's not that much. One technique here that we're showing, I don't know if I can make this a little bit, I think that's about as good as I got, That white part is a balloon. It's actually an angiography balloon, a venous angiography balloon that we place out of the outer catheter. We're going to get to a spot that's not too wide, ideally, and then we're going to occlude and get a occluded venogram. Why would you want to stop the flow at that point?
Maybe for better imaging of the vasculature?
Yeah.
The dye sticks there.
In this case, we're actually trying to force contrast upstream. We're trying to force it up the drain.
That's what we're seeing on the top part.
That's what you're seeing here. So there's occlusion,
Yeah,
contrast in the CS.
yeah.
This is the AIV up here, and this is a lateral branch going down the left side of the heart. So this is where we would target.
So we're occluding with the balloon?
Yep, right here. So you blow up the balloon. So normally it's not inflated. It comes through the catheter, and there's a little side port that's got air in it. We test to make sure it doesn't leak, because what don't we want to introduce to the heart? What does air cause if you inject it into the heart? Air emboli, which causes?
Sure.
Well, it also causes pump failure, right?
Yeah.
Air is compressible, blood is not. If you try to squeeze on air, it's gonna squeeze, right? And then you get sudden cardiac arrest. Bad things follow. So, if you inject on the left, you can actually get air emboli into the coronary arteries, which is really bad. And the brain, yeah, that's also bad.
So is the reason why you blew up this balloon because before you blew up the balloon, you didn't see that branch?
Typically, yeah, you can flush through an open pipe, right? You can basically stand in that drain and just shoot contrast out of the end of the catheter.
Mm-hmm.
But you've got return blood flow coming at you, so it's not going to go very far,
Oh,
and you're going to have to use a lot more. So if this patient is renally compromised, you're putting in tons of contrast in this patient. It's not really helpful. They used to just inject like crazy, right, with tons of dye. But this is a tool to be able to allow to reduce that burden, right?
So like renal failure, right?
Right.
Yeah.
Yep.
Diabetic.
Yeah, that's bad. Then they have to go get dialyzed afterwards. It's no fun, right? You don't want to be responsible for that. So they're just kind of showing you, okay, first choice location is not suitable for an LV lead. If it's not, you've got options. You know, put in our fancy dancy lead and it saves the day. So this is kind of what it looks like. Ah, I got a great picture. So this is where the phrenic nerve is, right? Ways you can look for this. So when we say, okay, let's test for phrenic stimulation, we're going to pace it high output. We're going to do a couple different configurations. So we include different electrodes in case one of them's on the nerve and the other one isn't. And then we're going to look at the chest. We're going to feel the chest, feel the diaphragm, and you can actually pan down with the fluoro camera and look at it as well. Visualize to make sure it's not moving. It should be moving, but it should be moving with breathing, right? Not with us. So like if it's going 90 beats a minute, that's probably not a breath, right? That's a like that. All right, let's keep going here. So previously, if patients could not, and this still exists, if patients do not have good target vessels, if you just can't put anything there, we used to have to put in epicardial leads, and some patients still do get epicardial leads. So epicardial leads look like patches. They're big screw-in productions, and you can get those in via either a subxiphoid, so center, right, under the inferior tip of your sternum. They do a incision there and access the pericardial space, or they do a window, more common. I think it's just less traumatic to do a window on the side. Or you can do it during an open heart. If they were already having a CABG and we know that they're getting a BIV ICD, you get a twofer, then they do a couple screw-ins that way. It's very common practice that a physician, even though you'll only pace off of one, they put in 2 epicardial leads because the scar response for an epicardial lead is dramatically higher than the endocardial or endovascular response. So,
Aren't you just going to cause more scarring then?
well, you gotta pace something, right? So you deal with, there's steroid included on the tips of all these leads that help reduce inflammation response and scarring, but you're gonna get some. And so with scarring in an epicardial lead, if the scar doesn't conduct electricity, you get what's called exit block. So you might capture right by you, but it ain't going anywhere, and then you're not pacing.
Okay.
Right? So exit block is a big problem for epicardial patients, which is why we have the other one. So if they block, you go, this isn't working anymore, let's try the other one. They open it up, they plug in the new one, you're done. Right? Hopefully that one's got a better capture threshold. So very common to do too. All right.
What were they showing with the, I'm sorry, the previous
Uh-huh.
picture? What were they showing with the two circles, just like the different?
This is saying sites for pacing. Preferred pacing is often, so generally with a BiV, and this is kind of getting to the level of like if you're an implanting cardiologist, we might be, but you want to have the biggest separation between the pacing, right? If there's a big lever, right, if you got like a big lever to steer the two sides of the heart, that's a lot better than if you're only grabbing kind of one way over and you're trying to, move this ventricle starting here. You want to get as far apart as possible so that you can squeeze and start the impulses way apart. That's going to create the best resynchronization of the two chambers. And again, this is the most sophisticated part of devices and EPs, so there's going to be some things in here that you can let that go. But in this case, the upper circle is going to be a better site.
Okay, thank you.
As long as it's, viable, which means no diaphragmatic stim, means reasonable threshold, means, that's about it. Those two things. It fits, it stays. So this is just talking about, kind of the way that the implant procedure goes. So there's going to be, if you're familiar with coronary catheters at all, general principles of a catheter are going to be that they are plastic, they have valves, right? And they have atraumatic tips. That's going to be common for almost every catheter out there. Then you're going to have ones shaped for all sorts of different approaches, whether you're not doing a left-sided heart catheterization or right side. This is which? All devices go in on what side of the heart? Right. There are very few exceptions to that. I have never put a lead in the left ventricle, thankfully, right? If you goof and put it in the artery, it might go there, but you should know the difference. So the catheter at the top here has a little introducer tool. You'll see him use one of those. It allows you to dilate what's called a hemostatic valve here. That's again to prevent back bleeding as well, bleeding out, right? You don't want to insanguinate the patient by sticking a tube in and not putting a cap on it. That's bad, right? They generally check how much blood has come out. You don't want to have to give a transfusion during a pacemaker implant. It also prevents air from going in. No air embolism. It's got a little handle. So he's going to use things like this in order to manipulate the LV catheter in. The other leads go in just using a stylet. So a stylet is just a little wire that goes down the center of them, right? The lumen of any of these catheters, or even the lumen of a lead, is the what? You're familiar with the lumen? It's the center tube. It's the inside, right? So the lumen of a tunnel is the inside, right? Water flows, through the center of the lumen. So we've got a little, side port on these things to be able to flush saline or pull back and be able to make sure that we don't have clot in there. Physician's going to do a lot of in all of cardiology, there's a lot of catheter management procedures. So you're going to see him doing that, making sure that you're not pushing clot in or letting blood come out or air go in. A lot of that is managed by the valve, but the physician has to be kind of fastidious about what they're sticking in there. We're also going to use guide wires, which so these are our main catheter shapes, different hearts. We kind of pick this based on the approach. So you get in there and maybe you need to make a tight bend. We've got something for that. Got little inner guys that are even smaller. Some of these you can actually stick the lead through, so you can do 2 catheters that you then have to slit. And then comes, every brand has their own version, but this is ours. It's lovingly called the Lady Bic. I'm not sure that that's the official marketing term, but basically it's got a blade at the end, which is designed to go into the catheter and not buck out of it and cut the wall open. So we've got those leads in, we've got the catheters in. Now we have to get the system out of there without moving the lead. That's the challenge. And so you can do ones that peel, like a regular sheath, if you've seen peelable sheaths for devices, right? Coronary sheaths For femoral access, don't slit. You don't need to. Everything's coming out. But in this case, something's got to stay. So you can't pull the lead out and go, okay, well, we got the sheath out. How do I? It's got to stay. So you got to pull it off. You got to peel it like a banana, right? Or cut it like a banana, I guess, with a banana knife. So we're going to use this and basically break the hub and then move the sheath off the lead while another person, scrub nurse or fellow, is managing that to make sure we don't pull it out. That's always a tenuous moment, right? You do not want to dislodge your lead while you're slitting. All right. And they're going to talk about more awesome St. Jude stuff, which we're not going to use tomorrow. This is what a guide wire looks like on the inside, by the way. So there's a wire, which is a solid wire in the center. And then they use this like basically coiled tiny wire that goes around the outside. And then it's coated with plastic and chemicals.
The shaping ribbon is the coiled, the shaping ribbon is the coiled wire?
Yes, correct. There's actually something inside here to allow them to, but this outer part is like a coiled wire on the outside. I should probably plug this in. Wires come in different firmnesses and applications. Like all of cardiology, there's like a million flavors because physicians have different preferences and every patient's heart is different. All right, so we kind of already talked about things that are going to be challenges or often challenges within BiV implants. So BiV and a CRT, totally synonymous, right? What does CRT stand for again? Therapy, good, right? And a BiV is just biventricular. So things that get in the way or are challenges at the time, right? Bad veins, not enough veins, not a big enough vein, vein that's next to the nerve. Believe it or not, that little list can take up like 5 hours. So here is our target vessel. What is this guy right here? It is. Good, noticing that all of my answers are already on the slides. Yeah.
Diana knows how to read.
Right?
I actually didn't read it.
So we're going to approach from up here, right? What vessel is this? Good. And above that is the innominate junction, right? And then you have your subclavian veins. So we're usually going to go from the left. And the question that lots of little old ladies ask me after I go, is it on the left or the right? Is, aren't they all on the left? And I'm like, well, most of the time. Why most of the time? Is because of the shape and the approach. We want to go in one big curve. And these are actually human studies that they show for this, of the right atrium. So you can see a few things here, right? You've got, at the bottom right-hand corner, see the little stringy things? This is what?
Capillary muscles?
Yeah, exactly. Capillary muscles down here. So what valve is this? There's basically one main valve in a device implant that we deal with. Tricuspid valve. So I know it says Thebesian valve. That's up here. Right? There are often, and this is talking about some of the challenges of CRT therapy, is that sometimes there are valves blocking the CS, and that valve is called the Thebesian valve. It is located in this triangular structure along the right atrial septum called the triangle of Koch, and then there is often a marker ridge called the eustachian ridge. Some more views of what different variants of CS ostia might look like. You can see this one's really narrow. You can see this one's kind of squeezed. This one's got a big valvular apparatus in the way. I don't really know what's wrong with that one, but it doesn't look normal. Here we go, very large. Yeah.
Wonderful description.
Right. There we go, yeah, concealed, very small, fenestrated. Right? Fenestrations mean webs. Today's vocabulary day. All right, so again, we have lots of different approaches to go at it. You'll see all of these in the bag, usually. They vary based on patient height, So you have really long ones, really short ones. And some more, no, everybody in here gets the short. You gotta be really tall. Like NBA tall. So here's kind of what the networks look like. You can see you've got, and this is kind of, this lines up with our prior picture. So here's the CSOS, and then right behind that on the end, or the epicardial surface, is this. So the main gutter, right, coronary sinus main body, leads straight to the great cardiac vein, and then you've got the AIV anterior vein. The ones we are willing to target have to be lateral. They have to be typically posterior lateral of the heart. And the reason for that is that the AIV sits on top of the septum. If the RV lead is in the septum, like a half an inch from here, and you put an LV lead here, what's the point? They have to be separated, right? If you're in between the RV and the LV and you're trying to deliver this therapy, it ain't gonna work because you're in the wrong place. You need to be either in the MCV, or the preferred vessels are the left lateral and posterior lateral veins. Left posterior veins. Wow, look at that. So we're just kind of talking about locations of the phrenic nerve again. You can see where they line up. So there's actually not only the one that we're concerned about in BiVs over here, the left side, but we can also be concerned if we have an atrial lead placed in just the right spot, you can actually get the other side. When we do cryoablation, it is a particular concern because the cryoballoon for the right superior vein goes about where on the back side of here, about where my mouse is at, and you can actually stun the phrenic nerve. But that's kind of a lesson for another day, cryoablation. All right. Again, fancy dancy lead makes everything better. Some patients do not respond. So either because they didn't get the stimulation in the proper spot, or because we did resynchronize them, but electrically speaking, but they still have heart failure because of either scar, chemistry, the electromechanical conduction just still doesn't produce a good contraction. That can happen. It has been made dramatically better, and the number of non-responders has been reduced by some new tools to better synchronize. So more poles, better. More mechanical and echo and computer optimizations of where to stimulate, and doing more sites, right? All of these improve patient's response, which makes grandma feel better, and us in turn feel better about her. Mm-hmm. So ours is one button, basically. It's called Quick Op. So if you see us running Quick Op, as long as they have conduction. So by the way, if the patient has a BiV, are they dependent necessarily? No. You pull up their BiV pacing percentages, and you'll see a lot of ways to look to see a patient's dependent. If you go, how much they pace the A, how much they pace the V. If the patient paces the V 99% of the time, it's usually a pretty good indicator that they are requiring that pacing. Mm-hmm. Not with a BiV though, right? A 99% pacing with the BiV means you're doing a good job. You're getting to pace. You want to pace the V. So you might just have short delays. So when we do a BiV gen change, and I think we probably have one coming up, one of the first things to do is extend them out and go, do they conduct? What's the underlying rhythm? We kind of talked about steps for a gen change.
So a BiV is always pacing, that's the goal? Ideally
always pacing the V, yes, right. The Vs.
Okay.
Yeah. You want to shorten up the AV delay to ensure, and this is actually an automatic test that allows us to do it. You want to shorten up that AV delay in order to make sure that you are running the show and not the His-Purkinje system. So you see, okay, how long does it take for the native QRS to come in? I'm going to go significantly shorter than that.
Okay.
All right. We can also optimize from one V to the other. This is going way into how to calculate that. So where in this case is the defibrilate?
Down there, back in the face area.
Where are you looking? Which one? This one, or this one?
No.
Number 1, number 2, number 3. What's the defib? Yep. In this case, I'm kind of tricking you because this is a pacing lead. But yes, this is the defibrillator or pacemaker RV lead. Where's the LV lead? Number 1, number 2, number 3.
2.
Number 2. Good. This is out in the lateral branch, right? It's going behind and then coming down. What's that?
Atrial.
It's an atrial lead with really crappy slack.
What do you mean crappy slack?
Well, the patient has pulled back the slack on this lead such that it is almost dislodged.
Okay.
If you pull back any farther than that, it's probably going to pull out. So we don't want to do that, right? There should be significantly more slack on that lead. Like, it should come down and then go up. Big J. But, you know, stuff happens. All right, so it's just talking about how the computer calculates these things. Again, I have to kind of, you know, adapt some approved presentations. All right. And we don't need to talk about that. That's an EP thing. Okay.
Is that like the Optival stuff?
It is like Optival. Darn it, you know about Optival. All right, just a moment.
You already taught us Optival.
Okay, so Optival, ours is actually called CoreView. So we did it on a Medtronic device. Optival measures lung field fluid impedance. And so which has higher resistance, air or water?
Water.
Think about electricity flowing through the thing. Does it flow more readily through air or water? More readily through water. So who has a higher resistance? Air. Air has really high resistance. It's like in the thousands, right? Water has low resistance. So when you introduce air into that field, as you should in your lungs, you're going to have some number that you calculate as your resistance for this circuit, right, that goes across the lung field. And we're using the device here because we have the opportunity. We've got a can up here, and we've got a lead down here, and in the middle, basically, there's a little bit of lung. So when you introduce fluid, what's going to happen to the resistance? It goes down. And the device can track that. And you get a graph, which looks like that. So ours does resistance. Theirs does heart failure, right? They have an Optival metric, basically, in that you can flip them. So just know if you're looking, these are competitive algorithms. Because of the nature of proprietary technology, you can't register them in the same way. I think ohms makes sense. But basically, if ours goes down, more heart failure, right? More water. If theirs goes up, more heart failure, more water. So, but both are labeled pretty well, so you can see. The little bars at the bottom of ours also they'll tell you how many days they had a below average excursion. And so there's a rolling average line here. Both systems kind of work like this. There's like a rolling average because things change over time. And then there's acute changes. So there's like a live line and a reference line. When the live line really dramatically goes away from the reference line, you know you've got an event. And so 1, 2, 3 significant events of 7, 10, and 17 days in duration. That's kind of how that works. So if you saw this, and a lot of clinics will actually use this information in order to manage their patients proactively, and go, so they'll have a heart failure nurse who sits at a portal and logs in and monitors all their people with high voltage devices that can monitor this, and potential heart failure patients. They go, he's on day 7. Typically, they don't have to go to the hospital until like day 13, 14, 15. So if you can get him on day 7, 10, 11, and go, hey, take your water pill, call him up. And there's actually been some studies that allow this device to automatically notify the patient via a Palm, well, it's not Palm Pilot anymore, but like a app, right? That tweets, if you will, the language of the young people. It's like a very small Twitter feed. It tells you, okay, adjust your medication appropriately, and then your edema goes down, because one of the impacts of heart failure, right, is you get fluid retention. So you can actually reduce that fluid, takes the load off the heart, and reduces symptoms. Okay. Conclusion, this is the most challenging procedure, one of the most challenging procedures in EP. Tomorrow we're basically adding one lead, but if you did all three, it's one of the longest procedures too. It can go anywhere between, 45 minutes and 5 hours. That is that one.